Hello and welcome. Good morning, good afternoon, good evening. Thank you so much for joining this session. We're so happy to have you here today. We're going to be talking about stillbirths, data and parents' voice to end preventable deaths. My name is Allison Moran, and I work at the World Health Organization in the Department of Maternal, Newborn, Child, Adolescent Health and Aging. And I have the privilege of co-hosting this session today with my colleague, Dr. Gagan Gupta from UNICEF, who will be joining us later in this session. So we're really excited to have the opportunity to talk with you today about this really important session. We're going to be talking about stillbirths, where we have about still 2 million stillbirths every year, a huge burden, and is mostly invisible to many of us. So we really want to have an opportunity to speak with you today about both programmatic approaches and ways for strengthening data systems to better capture this really important issue that impacts women's families, healthcare workers, and their communities. So we're going to be focusing on a session where we're going to start first with this short overview presentation that will give you an update on the latest estimates on stillbirths from 2000 to 2019. And then we'll have a moderated panel discussion with a variety of different parents and public health professionals and their personal experiences of stillbirths and what's needed from the global community to really address this issue and end preventable deaths. So first, we're going to start with a global overview of the 2020 stillbirth estimates. And my colleague, Lucia Hug from UNICEF will be presenting that for us. And before we move to that presentation, I just want to remind everybody, we want to have time for questions and answers at the end of this session. So please make sure to put your questions into the chat, and we'll be sure to answer them throughout the session and also through the interactive Q&A session during the last 10 minutes or so of this session. So thank you again for joining. And I'm going to turn it over now to Lucia to give us an overview of the global picture of stillbirths.
Good morning, good afternoon, and good evening, everybody, wherever this may find you. I'm Lucia Hag. I work at UNICEF and I'm going to talk about the stillbirth estimates we recently launched last year that we produced together with WHO, the World Bank, and the United Nations as part of the United Nations Interagency Group for Child Mortality Estimation. And I'm going to talk about the global burden of the stillbirths. So in order to produce stillbirth estimates, it's very critical to have data on stillbirths. And many countries, unfortunately, have poor quality data or no stillbirth data at all. So in total, we find that almost 30% of the countries we produce stillbirth estimates for, like these are 195 countries, we have no data on stillbirths, or the data have poor quality, so we cannot use them in the modeling. And many of these countries with no data are high burden countries in sub-Saharan Africa or in lower middle income countries, where around 44 to 40% of the countries have no data at all. And you can see that on the map on the right, where you see in Europe and Northern America or Australia and Oceania, we have large circles here that indicate a large amount of data, while we see a lot of countries in the other regions with no data, where there's no, basically a country is empty, so we have no actual data that inform these estimates. So counting stillbirths and strengthening data collection and improving data quality is key to fill in the enormous data gaps we have in stillbirth estimates. And these are just, we're looking at the national data here, we don't even look at subnational. So if in order to find for that, we would even need more data that are critical to place interventions. So if you look at the stillbirth estimates that we produce, there's an enormous loss. And we see that over the past 2 decades, almost 48 million babies were stillborn. And that means today, still 2 million babies are stillborn, which translates in one stillbirth every 16 seconds. And these are not numbers, these are lives that are lost. These are mothers and families that suffer and face this tragedy every day. And these are unnecessary, and they are unseen and unrecognized and uncounted and are not prioritized. And why is that? Why are these numbers so large? There's a lot of taboo and stigma and misconception around stillbirths. And they're excluded from policies and programs. And they don't receive the necessary attention they deserve. And this mask, and often the pain and the cost that families experience is masked. So if you look here at the trends in the stillbirths that we estimated, we see globally the stillbirth rate has declined from 21.4 stillbirths per 1,000 total births to 13.9 in 2019. And we see the overall number of stillbirths has also declined from 2.9 million, but we still have around 2 million stillbirths every year occurring today. And if you look at the country level, we see huge disparities in the level of the stillbirth risk. We see that there's like across countries, it's a 23-fold difference between countries. And what we see here on the map, we see the darker colors are concentrated in the regions of sub-Saharan Africa and South Asia. And these regions really account for 3/4 of all global stillbirths. And the risk is also highest in the countries in those regions. For example, in the region of Sub-Saharan Africa, 1 in 46 babies are stillborn, while in Europe, Northern America, Australia, and New Zealand, this number is 1 in 30 and 1 in 321. So overall, and these are just the national disparities. We don't even look at the disparities at the subnational level. And if you look, when do these stillbirths occur? Globally, around 42% occur during labor, after the onset of labor. And if you look at the region, Sub-Saharan Africa and Southern Asia, this is almost half of the stillbirths that occur after the onset of labor, while in Europe, Northern America, and Australia, New Zealand, it's only 6% of them that occur after the onset of labor. And we see that the progress there has been reduction in stillbirth rates by about 30%, but it has been much slower than what we see for child mortality. The annual rate of reduction for stillbirth rate was 2.3%, while for the under 5 mortality rate it was 3.7% since the year 2000. And we don't see that these stillbirth rates the reduction has accelerated since 2010. It has remained very similar. The annual rate of reduction was 2.4 for 2000 to 2009. And was 2.1 for the most recent decade. And overall, we can see as the progress in reducing child mortality continues, and we have seen that since 2000, that if you combine the under 5 deaths and the stillbirths, previously they accounted for about 23%, while now they make up 36% of this burden. And we are at risk if this progress continues, that stillbirths are going to be left behind if we don't invest there further. With the ongoing COVID-19 pandemic, there's a threat for additional lives to be lost. In a simulation exercise we did, if we look at 12-month period and we assume severe health service disruptions, we could expect 200,000 additional stillbirths occurring in lower and middle income countries. But however, even before the pandemic, few women received timely and high quality care to prevent stillbirths in these countries. And if you look at half of the countries we analyzed, only 2 to 50% of pregnant women received key interventions that could prevent stillbirths. But we must say it's clear progress is possible. With sound policies, investments, and programs, we can make progress and reduce stillbirths. And for example, in Southern Asia, the region with the second highest stillbirth rate, there was a reduction of 44%. And 14 countries, including low and lower middle income countries, cut the stillbirth rate by more than half since 2000. And we really can say most stillbirths are preventable with life-saving interventions, high-quality care. And over 40% of stillbirths occur after the onset of labor, and many of these could be avoided with improved monitoring and timely access to emergency obstetric care when required. Without urgent action and accelerated progress, we expect that 20 million stillbirths will be occurring from now until 2030 if the current trends continue. And 56 countries are at risk to miss the enough target of 12 or fewer stillbirths per 1,000 total births by 2030. And that you can see that on the right-hand side in the map. These are the countries in red. These are the countries that are at risk to not meet this target. And 34 of them will only meet the target after 2050. And 45 countries need to actually more than double the current rate of progress in reducing to achieve the target in time. So we must do better and faster. If you need more information, you can look at the report we launched on stillbirths. as well as our website, childmortality.org, that has all the data and estimates and background resources. So thank you. And this was the overview on the stillbirth burden that based on the IGMI estimates.
Right. Thank you very much, Lucia, for that really helpful overview of where Hi, thank you very much, Lucia, for that really great overview on where we are with better understanding the levels and trends of stillbirths worldwide. So as you could see from that presentation, stillbirths are a very important issue and often invisible at many different levels. So have the honor and privilege today to have an excellent panel to talk about this with all of you, really focusing on personal experiences from women and healthcare workers and professionals about their personal experiences with stillbirths. So I would like to please turn it over to my colleague, Susanna Lesher, who is the mother of stillbirth son Wilder Daniel, excuse me, Susanna, the chair of the International Stillbirth Alliance, co-chair of the Stillbirth Advocacy Working Group, and a doctoral student in perinatal epidemiology at Columbia University. So over to you, Susanna, to introduce the panel and the speakers. Thank you.
Thank you so much, Allison. You're hearing me fine? Yes, perfect. So it's my privilege to introduce my fabulous friends and colleagues on this panel today. We have got Ijeoma T. Daniels from Nigeria. She's the mother of stillborn son Kamdi Chinobi. She's a writer and a content creator. We have Anuradha Talwar from India. She's an auditor and her son was stillborn at full term in 2000. We have Wanjiru Kihusa from Kenya. She's a mom of three, all three in her heart, but only one in her arms. She's the founder of Still a Mom, which is an organization that has supported many, many parents in Africa who have gone through pregnancy loss. And Raki Dandona from India is a professor of public health at the Public Health Foundation of India. And she's also the professor of health metrics at the Institute of Health Metrics and Evaluation in Seattle, and a board member of the International Stillbirth Alliance. As Allison introduced me, I'm also speaking on behalf of my own son, Wilder Daniel. I am so thrilled to be here with you all. And particularly because this is the only opportunity of the two-day virtual launch where we are hearing from parents who have experienced the loss of their babies. I would like to start with my friend Anuradha. Anuradha, tell us about the stillbirth of your son. What happened? How did it affect you and your family?
Can you hear me properly?
Yes, perfectly.
Okay. I was conceiving a baby in 2000 and it was full term. I was told to come to the hospital because it was over 9 months. So I was told to come to the hospital on January 26, 2000. And because I didn't had any labor pains at that time, I was induced labor pains. Everything, ultrasound at the last moment was normal. And I was induced labor pains. And while having my labor pains, doctor felt that fetal heart rate is feeble. It was weakening with the minute passing by. I was taken to the delivery room, delivery table, and I was told to push the baby out. So it was pushed so hard that my uterus ruptured. Baby was stillborn. I went into coma and I was taken to ICU, given CPR for 3 times, and I was there in coma for 3 months, precosmetized, and what my family went into trauma, that only God knows. And after 3 months, when I woke up and I got my senses back, I was not told that my baby was stillborn, and even my family was being told not to tell me, not to reveal this to me, because I can go into shock at that time. So after 1 or 2 months, I got to know when I pushed hard to my husband that I want to feed my baby and I want to see my baby. So he told me while he was crying, I still remember, he was crying at that time, our baby is no more. And moreover, we can't bear any more baby because my uterus is being ruptured and I went hysterectomy. All. So he was so depressed. I was so lost. Still, I thank God that I had won my daughter. So I still thank God. What I was being told by my doctors was I shouldn't have been alive. They were not talking about my baby. They were just talking about that we have done a favor, that you are being alive. You are still alive. You wouldn't have been alive at this particular moment. So that was the end of my story and what my family went through, I went through. I kept on crying. Whole night I used to cry. And I used to feel why this happened to me, why God has done this to me. Had I been at that time undergone cesarean, my child and me could have been saved. So I should say this was all in the hands of doctor and practitioners who are taking care of, who are delivering the um, lady. That
Thank you, Anuradha, for telling us a little bit about the death of your son. I think I have a lot of questions that I'd like to ask you, but I'm going to wait and go now to Ijayoma, whose baby boy was also stillborn very, very recently, and ask you, Ijayoma, to tell us the story of what happened and how did that affect your family?
Hi. I found out I was pregnant in in March of 2020, and at the time I found out I was pregnant, I didn't know if I wanted to keep the pregnancy or not because my daughter had just been diagnosed of spinal muscular atrophy, which is a neuromuscular disease that causes deterioration of the muscles. So, and it was a genetic condition. So the doctors had advised that we should wait and get tested before we consider having any more children. So it was after getting the diagnosis that I found out I was pregnant. So there was still the emotional struggle of whether to keep the pregnancy or not. And eventually we decided, okay, let's just keep the pregnancy. Whatever happens, happens. It was a smooth pregnancy, not no issues at all. The only thing I was concerned about was I just kept during my ultrasound scans, I just kept asking, hope everything is fine, hope there are no growth issues, because I had growth issues with my daughter. And the specialist kept assuring me that everything was fine, the baby was growing fine, everything was all right. And at 36 weeks, I started having very strong contractions, but they weren't really labor. So when the doctors checked me, they said, you are not in labor. They are very strong Braxton Hicks and all. So when I completed 37 weeks, the doctor said, okay, they should just induce me and bring out the baby. Maybe the baby wants to, maybe it's time for the baby to come out, and 37 weeks is safe. And I was induced and went through the labor. That was in November of 2020. Went through the labor. It wasn't a very long labor, just about 4 hours. But towards the end of the labor, I just kept saying that I wasn't feeling well. I wasn't feeling too good and all of that. But everybody just kept encouraging me. It's just in the next few minutes, this will be over with. And by the time I had the last push and I was relieved that the baby was out, but everywhere was quiet. There was this silence in the room. It wasn't the baby's cry. I wasn't hearing the baby's cry. The doctor was quiet. My husband was quiet. And I asked what's going on. And I had the doctor say, we have to resuscitate this baby. And I was shocked. Resuscitate what baby? Why? And all of that. And I guess the doctors did all they could do. The doctor tried to do what he could do, try to do some CPR and all, and the baby wasn't responding. So they found out that the baby had omphalocele. It means that during development in the womb, the whole of his intestines didn't go back into the stomach. So a little part of the intestine was still outside, and the doctors just assumed that probably if they had seen it while I was pregnant, maybe they would have suggested a cesarean section and the baby may have survived. But after the whole thing, I read and I saw that babies still survive, babies with omphalocele still survive births, and it was just a little bit of carelessness, not focusing on what was supposed to, and that was it. I didn't get to find out that my baby had died until the next day, when every of my family members had come to the hospital to kind of console me and tell me all of that. Or tell me what happened, and so that was what my experience with stillbirth was.
You know, Ijeoma, you said that one of the things you first said is what's going on. And I remember saying that exact phrase myself when the instant that the heartbeat of my baby was no more. What's going on is the question. Anuradha, I think that a question many people may have is, wow, your baby died 20 years ago and you still remember. It's still in your heart. Can you, before we go to Wanjiru, can you talk for a moment, Anuradha, about explaining to the people who are listening why this is still fresh for you even after 20 years?
I think no mother can forget this experience. Baby is the most precious thing for every mother, every woman. Conceiving, and when you feel the moment in your stomach, you feel every inch of it. Every day, you feel that baby in your stomach. And I used to feel it. And it was just, I couldn't hold it in my arms. It just went away like this. How can you forget? You can't forget.
Thank you. I want to ask Wanjiru a question. Wanjiru is a mom of three, as I said, only one of whom is alive now. And you founded, Wanjiru, you founded this organization to support mothers and fathers after a baby's death. Can you talk to us about why you founded this organization? What is the need out there?
Thank you so much for that question. So we lost our daughter at 20 weeks of pregnancy, which is usually not really defined as a stillbirth in most countries, but either way, you know, a baby died. I didn't even make it to the labor room. I delivered on my hospital bed, and it was a very traumatic experience. And when my husband and I shared with a couple of friends at the moment, I also shared a bit on social media, and I asked, do you people know, is there anybody who knows of support groups or support forums for people who have lost a child? I didn't get any, but what happened is my inboxes went crazy with all these people who wanted help, who wanted a similar forum. I actually do remember calling a counseling center in Kenya, and they said, if you start something like that, we will help you. And it is an extremely necessary support forum that all women and even men, basically bereaved parents, need a support forum from the moment they lose the baby. So some form of support at the hospital, some form of support when they go back home. So that means from their friends and family members, and some form of support from the people that surround them. It could be going back to work, employers who are understanding, you know, providing leave, maternity leave, should that be needed. So basically just all around supporting of the bereaved parent.
How do you, when you hear, Wanjiru, the stories of Ijeoma and Anuradha and what was done or not done to support our friends, what do you see that should have been done differently?
it really breaks my heart. And it's sad that over 5,000 parents that we have supported as Still a Mom, the stories are the same. They just feel like some of them feel that there is medical negligence, but a lot of them will admit that the doctors did everything they could to save their child. However, they do say that there's a gap in compassionate care, you know? So here we could look at it as giving information to this mother. Both Ijeoma and Anuradha said that nobody spoke to them. Nobody told them that, you know, we don't have a heartbeat, we are going to induce you, like just walk with the parent. It's not scary information that will make them break down. It is actually better to tell them than to leave them in the dark and have all these procedures, all these doctors passing around your bed, you know, somebody connecting the drip and nobody is talking to you. So speak out to them, let these parents know what is going on. If you can even give them like information beforehand so they can decide, do they want to see their child? Do they want to hold their baby? Like those are the decisions they can make if you give them the relevant information. Do not remove that right from them. I have spoken with a lot of medical professionals and we've been doing a lot of training in some Kenyan hospitals. And someone will ask me, why would somebody want to see a dead baby? And I keep telling them, that's not a dead baby to them, that's their baby. You know, that's a baby they carried this far. They want to see that child, you know, and some of them are actually a little scared to see. And, you know, a mom once told me that she told her husband to take some pictures, and 6 months into her grieving journey, she said she felt ready to finally look at those photos. So the realization that you're giving some really bad news to this person, what can you do to make this period of time as easy as possible for them? Whatever they will always remember this as the beginning of their grief journey. And I promise you, if you handle this correctly, you can aid and make it a little bit better. It's already a bad situation, but you can make it a little bit better. So that would be a really great place for people to start.
Thank you so much, Wanjiro. And this sets up my question for Rocky very well, which is, Rocky, sitting in India, why do we see over and over the lack of support for women and families? What is being done in India right now to support women and families after their babies are stillborn? What are the blockages? Why are there blockages?
Thanks, Anne, very much. I should thank Anuradha, Ijeoma, and Wanjuru for sharing about your babies. It's not easy, but the attention that you bring to stillbirth is truly what we need to move forward. So thank you very much. Zan, to answer your question, what's surprising and not surprising on the same level is all the stories, as Wanjuru also said, are similar. It really doesn't matter whether you're in Africa or India. I hear the same thing with the parents. I hear and see a similar approach of health providers, how they deal with the parents. In fact, the kind of stillbirth work that we do have been doing over many years now. And we said, many of the research studies that we would do, we will bring attention to stillbirths. But one big gap that we realized was all that is fine. We can talk about it, we can write about it. But until the parents start to talk about it, there's only so much difference that we can make. Which was a good realization, a very honest realization. But interestingly, practically, when we went about doing it, we realized that how would parents talk about it, because no one talks to parents about it. As Wanjuru said, you have health providers coming in, coming out, monitoring you all the time, but no one has time to actually tell you what's happening. And exactly what you said, that's all that goes on parents' mind of what is happening, and nobody's there to tell them until they find out that the baby is stillborn. And we realized that many parents do actually want to talk about it. Many parents want to hold their babies, but they are not given that option, assuming that they don't want to hold their babies. Again, what Wanjuru said, you've taken away the right of the mother and the parent to decide whether they want to see and hold their babies. And unfortunately, many of them are cremated on the way home. They're not even taken home. And that's stigma and taboo in India because you don't talk about it. So all this put together, we realized that, if the health providers start to talk about it, That's an important step that we need in India for parents to get courage to talk about it. Right? Because many times parents are just assuming things, it's our fault, we don't know what happened, doctor tried enough, but there are many, many ways how you can explain to the parent what happened, which makes grieving easy, which also makes more information available to the community at large as people talk with these parents, other people try to understand that there is stillbirth, this is what this is how it could happen. So it actually percolates information down. So as part of that, what we are now doing, what we are involved with ISA, International Stillbirth Support, and PMNCH support is a project called Parent Voice Initiative. And it's interesting, we want to bring parents' voices, but the first step in that project for us is getting the health workers to talk about it. So we are developing a toolkit for the health providers to tell them that it's okay to talk about it. You need to talk about it, and there is a manner in which you need to talk about it. And that's the first step for us to then we will take it forward to parents and give them that perspective as to how they can have conversation with the doctors, with community, with their family members, so that we actually make stillbirths less visible, get people to talk about them, and so that we can actually move forward in taking action. So that's the plan for India.
Thank you so much, Rocky. I mean, you and One Zero together have raised so many actions that need to be taken to support parents. And I just, Ijeoma, I'm going to ask you, there seems to be a belief among so many people that moms of stillborn babies don't want to talk about it, or that people are afraid to talk to you about it. Who can you talk to? Who have you been talking to about the stillbirth of your son? And do you feel like people are open and comfortable talking about it, or do you feel some blockages?
Okay, when I thank you for that question, because I really it was one of the challenges I had. I'm in a circle where I'm always the strongest among my friends. Always the people, when people are going through challenges, they're able to come to talk to me, and I'm able to encourage them. So at this point, it was more like I still needed to be strong. I still needed to show that I'm not so heartbroken and all of that. And it was a struggle because a part of me wanted to speak about it, and people who are, it was more or less like there was no one really to talk to. And then the only people that I could talk to were my mom and my sister, and they didn't want to hear it. For every time because I just wanted to talk about my experience. I want to talk about the labor experience. Was like the more I talk about it, the more I was preserving the memory of my child. When I talk about the labor experience and all, but they didn't want to hear it. For every time I raised the topic, they just shut me down and shut me up and told me to keep quiet. And because will I say therapy is not something very common in Nigeria. We believe that therapy is an Oyibo thing, like it's a Western world thing, is the Westerners that go for therapy. We don't need it. We are strong people. And I had a lot to say. I had a lot to talk about, and I didn't have anybody to talk to about them. So what I just did was I started writing a letter to my son, because I'm a writer. So I started writing a letter to my son. So I would wake up because I blamed myself. I was depressed the first few months that I found out I was pregnant because of my daughter's diagnosis, and also I felt maybe my being depressed sent him a message that I didn't want him, and he had to go. So I had to start writing a letter to him to say forgive me for everything. I didn't have anybody to say these things to, so I just had to write. I wish that from the hospital, there was someone directing me, okay, you can go for therapy sessions starting from next week. This is a therapist you're going to meet and all of that. It's easier if this is someone you are expected to talk to than for you searching for someone to talk to. It's easier the other way.
Yep. Thank you, Ijeoma. It's hard to keep talking and have this conversation when we're talking about such heartfelt things. These are very, very heavy things. Anuradha, who do you talk to? Who were you able to talk to? Did you find that people didn't want to hear?
That's certainly very right. Nobody wanted to hear this. I used to talk to my sister. Sometimes I used to talk to myself. Like Ijeoma has said, I used to blame myself. Maybe I was impatient at that time. Maybe that child was not in my destiny. Why did I bear him? So this question was really, really very difficult to answer. Most of the time, whenever I wanted to talk to my mother, they used to calm me down. Please don't start it up. Whenever I used to talk to my husband, even he used to say, please don't talk it. Stop. So this topic was, it was capital us only. I used to talk to myself. As I told you, I used to cry whole night why it happened to me. I used to blame myself, and I used to ask God why it happened to me.
So,
Why this happened?
so I want to ask Wanjiru something about what Rocky said, which is, Rocky, you were talking about how health workers may feel that, that no one has the time to tell the mom what happened. No one has the time. The doctors and nurses are all busy delivering other babies, and nobody has the time. Wanjiru, what do you think about that? Do doctors and nurses and midwives, do they have any time to have compassionate care, or is that just an extra?
First of all, when we do training with people that work like midwives, gynecologists, we call it respectful bereavement care. And yes, they have time. Here's the thing. We have to realize that we are all working together. The medical fraternity, those of us that run support forums for bereaved parents, the bereaved parents themselves, those in advocacy, HRs, all of us are really just trying to make this bad experience into a good one. Yeah, nobody, it's not like I'm telling the medical fraternity, you guys are reckless, you don't do your job properly. That's not where it's coming from. A lot of the time, and hospitals in Africa, for example, may not really move a bereaved parent into a private room. We don't have that luxury. Let's be honest. They may not even move you out of labor ward, and you have to spend the night hearing other people's babies crying and yours didn't make it. But sometimes a nurse will come and tell you, I have room in the regular maternity, and they will move you. So to be honest, a lot of it does not, what we are asking does not mean we look for new infrastructure, add more funding. Like, we are not asking for ridiculous new interventions. It is, what can you do in your current space with the current circumstances that you have to make this experience a little bit bearable. We have a hospital we work with in Kenya that has this purple ribbon they put on the bed when somebody has lost a child. And it just alerts, and they have trained their staff. It alerts that when the person bringing my food comes to my bedside, they don't ask me, where is your baby? Why are you not breastfeeding? They know what that ribbon means. It's just a simple, cheap ribbon, but everybody knows what it means. So yes, we have time for compassionate care. And one of the exercises we do with medical staff is, whenever we start out the training, we let them imagine they're pregnant. We let them imagine that they've come for prenatal care. And then we say, you come for your ultrasound and they have told you that there's no heartbeat. We let them imagine how it feels to be in those shoes. And then all of a sudden, they realize the beauty of compassionate care.
Thank you, Wanjiru. We're out of time for now, but I think we can hear a few things, which is, number one, these are babies who matter to individuals. And number two, we don't forget. Number three, everybody's experience is unique in some way, but there are some commonalities. We want a voice, we want to be heard, and we feel that there is time for compassionate care. I want to thank each and every one of you for your courage in opening up some part of your private lives to the people who are watching. Thanks.
Thank you.
I think we're going over to Q&A now.
Great. Thank you so much, Susanna. for moderating such an amazing panel. And I really want to give my heartfelt thanks to the panelists for sharing such personal and moving stories with us so that we can better understand this issue and think together about how we can better address this and ensure that all women receive compassionate care, whether they end up with a live baby or a baby who may have died. It's really, really important. So thank you very much for sharing that with us. And we do have a little bit of time for questions and answers. So I encourage people, if you have any comments or questions, please do add them in the chat. One of the issues or one of the things that one of our colleagues on the chat raised was that, you know, sometimes maybe the health provider might think the parents might not be able to handle the information or might not be interested to know what's happening or might not be able to process the detailed medical information that they might want to share. So I heard from all of you on the panel that actually you do want to have that information. So it'd be interesting to hear if one or two of you want to respond to that comment or question and what your suggestion would be so that we can ensure that health providers provide the information that would be most useful as parents in these types of situations. So maybe we'll go first to you, Wanjiro, because you're first on my picture. Go ahead, please.
I think what I would say is don't decide for the parents what they should or should not hear. Just think of it as they have been on this journey for a really, really long time, really expecting this baby and they have been making plans for this baby. So they definitely need to hear. And should their situation, you know, escalate and they have trouble handling the news that you have given to them, I think almost every hospital that I know of has some form of therapist. Some religious hospitals have a chaplain on call. So you can do that alongside, as you give the news, you can have a support staff alongside should they want to talk to that person a little bit more.
Mm.
Yeah.
I would also add, though, that it's important to acknowledge that, as I mentioned, everybody's experience is unique in some way. And so the point is to provide the mother with options. The mother may not want to have certain, see or hold the baby, but the mother should always be given the opportunity to make that choice. The mother may not be ready at one particular time to hear what's happening, but that choice should be given to her regularly, at least several times. Wait a few hours, see how she's doing, and then offer the opportunity for a conversation again. So it should be the mother's right to choose.
If I can also add, listen, there are experience in India, 2 points from that. One is, the realization that these health providers also come from the same community as parents, right? So they also come with the same notion of what community believes about not talking about stillbirths. And that's a realization that came to us, and the assumption that they don't want to talk about stillbirths is we kind of make that assumption because they're health providers, they need to talk about it because parents need to know. So we had this workshop with health providers very recently, and we went with that assumption that health providers don't want to talk about it. But we were very surprised, and they said, yes, some of them said, yes, we actually want to talk about it, but we don't know how to talk about it. Which was a very interesting learning for us, because we really haven't trained our health providers, as Wanjiro was saying, how do you actually talk about it? Because many of them also have to deal with the fact that a stillborn baby has born. It may be a different way of dealing with it than the parent, but they also need to deal with the fact that the baby wasn't born alive. So something for us to keep in mind that, maybe the health providers want to talk about it. We need to give them the tools to talk about it. Right. Thank you.
Yeah, great. No, thank you very much. I think those are all really important points. And I don't know if anyone else has one quick thing they want to add before we wrap up on this question.
Okay, let me just add something, which is a general statement people make to me. A few weeks ago, I made a post on my social media, and I was talking about what not to say to someone who just lost a child. And most people said they really want to condole with someone who just lost a child, but they don't know what are the right words to say. And one thing I said is never tell the person a better child will come, because it means you're telling the person, I mean, I'm already dealing with guilt that my body failed this child, or I failed this child, and then you come and tell me that a better child will come, meaning this child wasn't good enough. My body didn't produce a good enough child. Please, so as much as possible, just avoid saying some kind of things. That child is a child that cannot be forgotten and cannot be replaced. That's one thing we should bear in mind.
Yes,
Thank you.
Thank you very much. That's a really good point to end on. So I just want to thank you all again for sharing your personal stories and these really important messages for how we can move forward together as a community. And I'm going to hand it over to my colleague Gagan Gupta from UNICEF to do one last quick closing, and then we'll end the session. Gagan?
Thanks, Alison, for the brilliant moderating, and for all of you for sharing the stories, which were so difficult to hear, but will probably help a lot of us in terms of planning and moving forward. Not only the worrying factor is the 2 million stillbirths, but the very fact that nearly 34 countries will not be meeting the target of stillbirths set in the INA by 2050. That means really a lot of efforts needs to be done. And these efforts needs to be done primarily in sub-Saharan Africa and South Asia, which account for the maximum burden of stillbirths, and around the period of childbirth and antenatal care. If we are able to optimally utilize the period around childbirth, we can make a significant impact, because nearly half of the stillbirths in these regions are happening around the period of childbirth. If you see America region or the European region, nearly 90% of them are antenatal. So I think that is important that sub-Saharan Africa and South Asia starts improving on those parameters. As program managers who are logged in today, there are a few things which I would like to tell you. What is the hook for you to move this agenda? I think the best hook and the platform for you to move the stillbirth agenda in your own countries and your own programs is the ENAP platform, the Every Newborn Action Plan. It sets a global target for 2030 for stillbirth, which is generally missing in the SDG. Second, it also has subnational targets of coverage for both institutional delivery and antenatal care. And if you are able to, and plus it tracks progress. So you have a set target, you have subnational targets, and you have tracking of the progress on a regular basis. So use ENAP as the most important platform in your country to push either for advocacy or for action. Number two, the Quality of Care Network. Quality of Care Network is doing a brilliant job, and it's expanding. And yesterday you heard a lot about the Quality of Care Network. But single most important indicator for quality of care for mother and newborn should be the stillbirth rate. If any quality of care initiative in a facility is not able to bring the stillbirth rate down, then probably something is missing and we don't need to go back to the drawing board. So I think with these words, my closing remarks would be the cost is too high. The continuum of impact is across all families, communities, health systems, the government, the financing, and the policy. So we cannot be slow on this. And as UNICEF and WHO, we are working together very hard on that. And we hope that whatever support is needed for the countries will be willing to provide. Thank you so much.
Thank you very much, Gagan.
Over to you, Alison.
Great. No, thanks so much, Gagan. And I think with that, we'll conclude the session. Thank you again to our panel and for all the great comments and questions, and look forward to continuing to work together on this important issue moving forward. So we ensure that stillbirths are not forgotten and that we really do leverage the platforms that Gagan mentioned, as well as many things that came up in the panel discussion, so we can address this issue and make it visible and part of our everyday work. Thank you.